Good morning. Thank you, Dr. Phelps, and it's a pleasure to be here with all of you, especially now that I know that my good old friend, Dr. Carlos Cordo is here, the new chair of pathology. So we go a long way, I think probably more than 20 years since we first met. So Dr. Dubik gave us a very comprehensive talk about the molecular understanding of cutaneous T-cell lymphomas. We now know that such a mess, such a soup of letters, that's impossible to make any sense about what's happening. Is becoming very complex. I'm sure this complexity over time will clarify how we diagnose the disease and how we treat the disease. But we are at the point where it's like an abstract painting that we have lots of data. We don't know what are the drivers. We don't know what's important. We don't know what's less important. And I think in the next few years is when we'll probably try to distill the essence of all those important findings. So I'm a pathologist, I'm a dermatologist. I'll try to give you a brief and practical talk about my approach on cutaneous lymphomas, what I have observed in the last 25 years of working with patients with lymphomas. If you don't like the classification of cutaneous lymphomas, wait a few hours, it's going to change. It has been evolving. Since I'm in pathology, I've seen literally like 10 different classifications. It keeps changing. In essence, we know that the majority of T-cell cutaneous lymphomas are of the T-cell type, with a minority, about 30% of B-cell lymphomas, which we'll talk on the second lecture for Dr. Subtil. So this is the WHO classification as it stands today. There is a new updated version coming up in the next few months that has very minor changes. It incorporates a new CD8, a small medium pleomorphic variant that's very acral, very extremely rare. And they finally have recognized that the small medium pleomorphic lymphomas are not true lymphomas, but more what they call lymphoproliferative disorders. We'll talk about this entity. So this evolution of the classification of cutaneous lymphomas pretty much reflects our present understanding of the complexity of the skin immune system. We know that the skin has more lymphocytes than the peripheral blood. So a huge lymphoid organ up until recently unknown. We know that most of those cells are mature T cells expressing the alpha-beta heterodimer. Most of those cells reside permanently in the skin. They have skin homing markers like CLA, CCR4. Most of those cells in the dermal compartment are CD4. In the epidermal, the ones that circulate, they tend to be CD8 positive. There is also a subset of cells that comes and goes. Those are the central memory T cells that, besides the skin homing molecules, they also express CCR7. A small component of T regulatory cells and a small component of the innate immune system. So now we know that we have pretty much a malignant counterpart for every one of those T cell subsets, and we'll talk about some of those subsets. Mycosis fungoides is the prototype of cutaneous T cell lymphoma, for the most part CD4 positive, Th2 cytokine profile. We know that they can be changed on or plasticity of those cells in different directions. You can have a more psoriasis form, or lymphomatoid papillosis, which has a more Th17 cytokine profile. Follicular T helper cells play a role, as we will discuss. I'm going to talk, one of the vignettes is going to be on CD8 cutaneous lymphomas, a very difficult topic to discuss. Sézary syndrome, the central memory cells, few subsets of T regulatory cells and gamma deltas. I'm not going to cover everything because, again, it's too much to cover in 20 minutes. Briefly, let's talk about mycosis fungoides, the prototype of MF, of CTCL. Often the patient presenting with those poikilodermatous patches. Why is it so difficult for us to diagnose? Because microscopically, very few tumor cells, the cells home in the epidermis, lots of reactive cells, CD8 positive, NK cells. So it's pretty much similar to what happens with dysplastic nevi and the evolution of towards melanoma. Initially, we have a very robust cell-mediated immune response. We know that those cells, this is a chronic lymphoproliferative disorder like CLL, which means that the cells deviate minimally from the normal morphology of T cells. They are slightly larger, they are slightly more convoluted, they home in the skin. We know they need the signaling from the antigen-presenting cells, namely Langerhans cells in the epidermis. Those Poitiers microabscesses, you will always see these feeding Langerhans cells. They talk, they signal, is a dysfunctional relation, is not a healthy relation. Definitely abnormal. The cells, the malignant cells, secrete they express CTLA4, which ties them to the antigen-presenting cells. They secrete TGF-beta, recruits immature antigen-presenting cells, but at the same time, the malignant cell is pro-immune suppression. They secrete IL-10, which refrains the antigen-presenting cell from maturing, going to the node, and having a vaccine effect. So the cell is immune suppressive. They need the signal from the antigen-presenting cells. The nature of the antigen up until now is unknown. So why is it so difficult for us to know? Number one, the skin is easily approachable, so we biopsy all the time, so we can see the very early phases of lymphomagenesis, something we cannot see in nodal or bone marrow biopsy. We cannot take a bone marrow biopsy every other day. A skin, easy place to see those early phases. We know that's a mature cell. We know that is immunologically active. We know that depending on the nature of the antigenic stimulus, depending on the immune system of the patient, it may shift one way or the other. We know the majority of cells are Th2. We know that early on they elicit a strong immune response. Early lesions, as Dr. Tubig was mentioning, very much look inflammatory process. Th1, we know that in some cases we have this Th70 look more like psoriasis-like, follicular T helper, even Th9 in some cases. So very important to be aware of all this plasticity which reflects in this high heterogeneous presentation. Clinically, here we see some violaceous lichenoid lesions, some more eczematous. Some lesions are very necrotic or cytotoxic, and sometimes this is a conversion, a switch of phenotype. With tumor progression, the cells acquire TIA1, granzyme B, and they become necrotic like this. Some patients have alopecia from presentation. Remember, there are all these subsets of folliculotropic mycosis fungoides that clinically can resemble acne, can resemble alopecia areata, can resemble a cicatricial alopecia. So a huge mimic for folliculotropic MF, all the pathology of the hair follicle. For conventional MF, they can resemble any inflammatory dermatosis. Psoriasiform MF, again, as Dr. Dubik mentioned, it can be confused with psoriasis. Do not treat those patients with immune suppressions because you are going to trigger tumor progression. So just to show you a few examples, psoriasis-like, poikiloderma, folliculotropic, eczematous, again, why they are going different directions, not completely known yet, but something to work on. So Sézary syndrome. Sézary syndrome, as we mentioned, has different homing molecules. They express the CCR7, but anyway, in Sézary syndrome, what happens is that the patients, again, express CCR7, the central memory cell. Those cells are very much pro-immune suppression. Sézary syndrome, important to remember that the cells, patients with Sézary syndrome often have B-cell lymphoproliferative disorders, CLL, low-grade B-cell lymphomas. Often the cells express PD-1, CXCL13, and they can have a phenotype towards follicular T helper cell. So the cells are highly immune suppressive. That's why over time the patients get colonized with the Staph aureus, with more growth of bacteria. What you have is you have a more robust T cell response with IL-2 secretions, which has an effect on those cancer cells. This is a patient who came to see us with, the patient has ATLL. Those patients present with a waxing and waning papular process. They may present with erythroderma. Patients with HTLV1-induced adult T-cell leukemia lymphoma have a T regulatory phenotype. A T regulatory phenotype, some of those molecules like CTLA4, CD25, FOXP3, they can also be expressed in conventional MF, but by definition, the most immune suppressive of all of those is adult T-cell leukemia driven by a retrovirus. Again, remember that Sézary syndrome also with this PD-1 expression, also very pro-immune suppression. So adult T-cell leukemia, think about it when you have a patient with a papular presentation so they can have waxing and waning papular presentation or erythroderma. But notice how they can have also lots of exocytosis and epidermotropism. So histologically, they can totally resemble mycosis fungoides. Clinically, they may resemble a Sézary syndrome or even a papular variant of mycosis fungoides. The expression of strong expression, actually, of CD25, FOXP3 indicates that you are dealing with this condition, and then you check serology for the HTLV1. So we talk about those small, medium pleomorphic T-cell. The majority of those patients present with a localized lesion in the head and neck. There is new literature now that shows that most of those cases also have a follicular T helper phenotype. What's follicular T helper? Those are T cells that in the homeostasis reside in the germinal centers. They have growth factors. They express CXCL13, BCL6, PD-1, all those markers which are growth factors for B cells. So as a result, this malignancy or pseudomalignancy of T cells is accompanied by many B cells. That makes it very difficult for the pathologist to reach a diagnosis because you have a very mixed infiltrate. Often also very histiocyte rich, even with granulomatous changes. So PD-1 is a good marker that you are dealing with this condition. Another nice marker is you can do like double expression of CD3 and BCL6. You can prove that you are dealing with a follicular T helper process. So the issue in question is that those patients presenting with a single lesion, they have an excellent prognosis. I don't know of any case that has had a poor outcome, and that's what the literature shows. So why then are we calling those cases lymphoma if the outcome is so positive? Recent literature from the group from Holland also confirms that what we are now calling a small, medium pleomorphic T-cell lymphoma is what up until now has been called pseudolymphomas. So are we doing a service to the patients by labeling them with malignancy? No. But up until now, the WHO classification talks about this provisional entity. Again, the next version is going to be corrected, but provisional entity, patients with an 80% 5-year survival. So that's very frightening to the patients when you tell them you have a small, medium pleomorphic T-cell lymphoma, 80% survival. So where are the 20% of the cases that are aggressive? Those are the cases that we have labeled them as intertriginous mycosis fungoides or primary cutaneous follicular helper T-cell lymphomas. That's what up until recently we were reporting as mycosis fungoides, the Demblé presentation. The patients present from day one, not with one, but multiple papular nodular lesions without the background of patch disease. So this mycosis fungoides Demblé presentation. Often those tumors become ulcerated and in intertriginous areas. Often those cases have no epidermotropism. They have this granulomatous look, small, medium, atypical cells. Again, the co-expression of CD3, BCL6, and those are the ones that will do well. So again, recent literature shows that you cannot encase a lymphoma as follicular T helper Th2, Th9, Th17 because over time there is those cytokine phenotypes are unstable and they can switch over time. So keep in mind that advanced mycosis fungoides, advanced Sézary syndrome, often has this more follicular T helper phenotype, and PD-1 and expression of those markers may be noted. So when do we worry about a small, quote-unquote, a small medium pleomorphic T-cell lymphoma? When it's not unilesional. Multiple lesions, again, this intertriginous distribution, probably a more like pure malignant phenotype with less of this B-cell and granulomatous process. So again, for the T-cell talk, I have part 1, part 2, and part 3, but I'm going to go fast on the next 2 ones. I wanted to mention to you that, again, the majority of CTCLs are CD4, but pathologists and clinicians, we are all having a problem in diagnosing CD8 CTCL. There is a lot of confusion. Let me show you some of the cases. An elderly patient presenting with this popular hemorrhagic necrotic process clinically may look like pleva or lymphomatoid papillosis. The patient has a remote history of mycosis fungoides. That's what we see under the microscope, a pagetoid process of small, medium cells. What's the phenotype? CD8 positive. The pagetoid presentation is almost always CD8 positive. Granzyme, so all the cytotoxic markers are positive. Interestingly, there is co-expression of beta F1 and gamma M1. So alpha beta, gamma delta, heterodimers, both of them expressed. So the gamma M1 is a new marker in the last 10 years probably. We are learning that's not so clear-cut. Gamma delta, alpha beta, and in some occasions, especially with cytotoxic lymphomas, there may be a little bit of co-expression or overlap between those lymphomas. So this patient was has an aggressive, what's called primary cutaneous aggressive epidermotropic CD8 T-cell lymphoma, also known to simplify as Berti's lymphoma. Berti was very smart, came up with such a long name that nobody's using the name, so everybody refers to as Berti's lymphoma. So remember, if you discover a disease, to come up with a very long name. So the patient failed multiple treatments. A few months later, he was hospice and he died shortly after. Very few cases reported of this lymphoma. We have seen about 20 cases with our cytotoxic group that we are in the process of publishing. Most of those cytotoxic lymphomas, they have a very poor prognosis, this tendency for involvement of CNS, lung, testis, mucosa, and again, very, very poor prognosis. Oral lesions are seen in a good number of those patients. This is another patient. Notice the progression in a few months. Mucosal lesions, the lesions can be very serpiginous, they become necrotic. Once a lymphoma has this extensive erosive look, is a very poor sign that you are dealing with a cytotoxic case. So the opposite end of the spectrum, so we have those very aggressive cases that we used to call Catherine-Goodman cases. Now we know that they are those Berti's lymphomas, or some of them are gamma delta lymphomas. At the opposite end of the spectrum, we have those hypertrophic verrucous acral lesions, Warringer Collop disease, even though histologically can look very aggressively, they have a very benign course. So there is a third condition that also presents with this pagetoid pattern, and that's what's now called lymphomatoid papillosis type D. Those cases are CD8 positive, they are very pagetoid, but clinically they look very different. They are waxing and waning, small, hemorrhagic, necrotic, look like this one. This type of presentation could be two things. Lymphomatoid papillosis type D, epidermotropic CD8 positive, or type E, which is more vascular. Okay, there is more like an angiotropic type of infiltrate. Now, those type D are seen very frequently in children, and here we have another diagnostic dilemma, is that a lot of those cases, they do invariably super well, they do not have problems, they do not evolve into anything. The vast majority of those cases, they overlap with pityriasis lichenoides acuta. And that's a dilemma for us, that's a dilemma for the clinician. Are we going to call it a lymphoproliferative disorder? Remember that pleva is often clonal, so clonality is accepted in those patients. Those patients have a very impressive pathology, a very impressive clinical presentation, but they do well So I think we do a disservice to those patients by labeling them with a lymphoproliferative disorder. We have seen also in children a number of cases with this like PLEVA or LYP type D, if you will, with CD8 and gamma delta markers. So clearly an overlap between those gamma delta cells and alpha beta CD8 positive cells. Another area that I believe we overcall is what's called hypopigmented or juvenile CD8 positive. Those patients can really be the inflammatory phase of vitiligo. So be aware of those hypopigmented juvenile CD8 positive, often clonal, but a very indolent course. Panniculitic lymphomas, those cases are always CD8 positive. Remember, those cases do not ulcerate. If you have ulceration on one of those panniculitic lymphomas, you are not dealing with the CD8 subcutaneous panniculitic T-cell lymphoma. If you have ulceration, be aware that you have one of those aggressive gamma delta lymphomas. The rimming of the cells, CD8 positive, CD45RO, this is the typical phenotype. They are not gamma delta positive. So what are the difficulties in the diagnosis of panniculitic lymphomas? The main difficulty for us is that there is overlap with lupus panniculitis, especially so in children. You are going to find that there are cases that are difficult to diagnose. Often there is a positive T-cell clone if you send it for gene rearrangement. They often have a positive ANA. They often have mild pancytopenias. Remember that the true panniculitic lymphoma often has cytopenias because they often, if they have a poor outcome, is because they have a hemophagocytic syndrome. So those patients with T-cell rich panniculitis, always be at the look for clonality, always be at the look for signs of hemophagocytosis. So definitely overlap between lupus and panniculitic lymphomas. We have all seen, there are a few case reports, but we have all seen cases that have been misdiagnosed, or not misdiagnosed, but they have been reported as lupus panniculitis. They have mucin deposits, they have positive ANA, often they have vacuolar changes, often they have mucin deposits, and over time they turn into a true lymphoma. Another wild card in those cases is that if you do a gamma delta stain, you often have a significant subpopulation of gamma delta cells, especially in children. So be aware of all those pitfalls. Do not label those cases as lymphoma unless you are sure of it. Even the ones that are lymphomatous, they respond well to cyclosporin, which comes to tell you that in general they are indolent, with the exception about 1 in 5 patients of panniculitic lymphomas will develop the hemophagocytic syndrome, and they have a very poor outcome. There are also patients who have more like a granulomatous presentation, very much sarcoidal-like. We have published about 5 or 6 cases. Often those patients have immunoglobulin deficiencies. In this case was an IgA deficiencies. Those patients often have pulmonary problems, high ACE level, and look at how histologically looks very granulomatous, but with the presence of abnormal cells, CD8 positive. So also one important thing, again, I wanted to also emphasize that all those cases with granulomatous CTCL, you must check for EBV. Why? Because lymphomatoid granulomatosis, it can be a granulomatous necrotizing angiitis, very similar to those cases of Burton's hypoglobulinemia-induced CD8 lymphomas, but they are EBV positive, and those patients obviously are going to have a very poor outcome. So just briefly mention about clonality. Where are we in the whole issue of clonality? I've seen in my 25 years of working in dermatology the transition from southern blot to CR gels. Now we are using GeneScan. GeneScan works very well. You can have a nice identity of the clone with the size, the base pair size of the amplicon. Is it worth moving towards the high throughput sequencing, the next generation sequencing? So what are the issues with the GeneScan that we have now? We know that works well. We know that there are positive clones that do not mean malignancy. Remember about all those cutaneous lymphoid dyscrasias, elderly patients, HIV patients. Certain infections can give you a false positive clone. There are patients who have B and T cell clonality, especially certain lymphomas like the angioimmunoblastic T cell lymphoma, cross-lineage common in lymphoblastic and myeloid cases. So it's not ideal, but it works very well for all forms of lymphomas, except for maybe the CD30 anaplastic large cell lymphomas that has a slightly lower positivity, sensitivity rate. In the cutaneous infiltrated, it works very well. The more tumor burden you have in the skin, the better it works. So actually, one of our students from Northwestern is here, Tiffany Sun, who has been working with us in the last couple of summers. And she reviewed over 200 cases of T-cell lymphomas where we had more than one array of results. And we found that often patients with CTCL have a small subclones, like this case here, that are not reported. They are not reported because they do not fulfill the reporting criteria of more than 3 times the baseline. But over time, they may become important. And I'll show you a case report of a patient who failed therapy. And when there was recurrence of the disease, there was the emergence of a new clone that was a different base pair size, but had been identified early on and not reported. So we do have this variability of, so the clone is not a pure cell type. You may have some subclones that are dormant. You may have some subclones that will emerge when you fail a therapy. So similar to what happens with tuberculosis and resistance to antibiotics. And we've seen other cases by flow cytometry where, for instance, a CD52 negative population of cells is resistant to Campath and eventually emerges as the aggressive clone. So in the future, we may be using immune profiling with next generation sequencing. Right now, there are 2 commercial sets. There is Immunosec by Adaptive Biotechnology, the LymphoTrack. That gives you a complete spectrum, gives you the complete array, the repertoire of T cells. Why is this important? You are going to detect those subclones early on. You're going to find out if you have residual disease. And that's important, especially in patients with Sézary. You should not stop the therapy until you know that clone is completely gone. And remember that what I said before, all those malignancies are pro-immune suppression. Over time, all those T cell subsets go down, way, way down. So finding, for instance, post-transplants, when there is a reconstruction of the immune system, this type of technology is going to be very helpful. In addition, they give you the top 10 sequencing of the clone, so you have a precise signature of each one of those clones. So I'm going to leave it here with my email if you have any questions. I know I went fast. Thank you.